Beautiful. All right, just a reminder about how you guys can get the closed captions in case you want them. And if anybody has a question about it, please just put in the chat and Ellie and Theodora will help you walk through that. Next slide, Olivia. All right. Also, as you all know, this is a seminar series that is funded through a NIDA project. Our goal is to advance the science on recovery community centers, and we hope to do that by bringing together the different stakeholder groups engaged, which, advancing science is not just something scientists do. We do it in collaboration with everybody else impacted, including people who lead RCCs, people who go to RCCs, clinicians who might refer there, policymakers who are deciding how monies are being spent in the state, and so forth. This is the team here, the steering committee, where we kind of review what topics we cover in our series and what projects we're going to do next. So I always want to acknowledge that this group of people here. Next slide. As most of you also know, our project is one project that the National Institute on Drug Abuse funded, which focuses on recovery community centers. But they also funded a number of other network building hubs. And together we came together in the Consortium on Addiction Recovery Science. So this slide is our update in case you guys want to know what else is going on. All of you guys will get the slides emailed out to you guys probably Monday or Tuesday. And then you can see in more detail what's all in here. The thing I want to highlight here is if you guys are doing research on recovery support services, there's an excellent special issue dedicated exactly for this cause in Frontiers of Public Health. And it's at the bottom here. Check out these deadlines. It's a special issue that is being edited by people in the course network, myself included, and Ashley, who's here with us too. The deadline is for a summary in June, and then the actual paper is due at the end of October. So if you want to be part of a special issue, it's going to be highlighting a lot of recovery research, especially recovery support services research. This will be a wonderful opportunity to be in a very visible place in a collection of other like-minded papers. So I really want to plug that you guys submit a paper to that. All right, next slide. The other thing I want to plug is our ongoing list of RCCs. As you all know, we did do a study on a nationwide survey study of recovery community centers that exist nationwide. Since then, that list has grown quite a bit because more recovery community centers are being opened. We try to stay connected and on top of how many RCCs there are and where they're located, because if people reach out to us and say, I'm located in California and I want to collaborate with an RCC, who do you know in that area? So if you guys can send us the name of your RCC and the website, or just put it into the chat right here, right now, we'll add you to the list. And we also have that list, or we will have it publicly on our website. We always email it out, but we decided it would be easier to just put it on the website so you guys can download it at will. So do send us your contact information. We'll include you on that list and make it easier for folks to find you and collaborate with you on research in this space. Next slide, please. If you haven't already, we just wanted to plug our next seminar, which is going to be happening at the beginning of June. In that one, we are going to be looking at peer recovery support specialists working within a recovery community center. And the reason why we really want to highlight what this experience is like is because peer recovery support specialists work in a variety of settings, and we would argue that RCCs is a very special and particular setting. So we want to really highlight what that is like and feels like and what the issues there are. And we have guest speakers, presenters who are going to be participating in a moderate discussion with us, just like we did last time and like we are doing today. So I hope you will be able to join us. And I think Ellie just put the registration link into the chat so you can register straight away. Thank you, Ellie. Next slide, Olivia. All right. And then to ground us all in what is a recovery community center, knowing that each one is unique, we have with us Dottie Green today. Dottie, can you tell us what it is like to walk through the doors of your RCC?
Be happy to. So the foundation of what we do is we provide a warm, welcoming, safe, non-judgmental space where all paths to recovery are affirmed and celebrated. So everybody's welcome, and all of our services are free. We're led and operated by people with lived addiction or lived experience in addiction and recovery. And so the first thing that happens when somebody walks in is one of our peers greets them, invites them to sit down and chat, get a cup of coffee. Then we ask, how can we support your recovery today? A conversation ensues. The peer will tell them a little bit more about who we are and give them a tour, give them a calendar of all of our events. So I probably ought to tell you a little bit about what we do too, is that we offer recovery coaching, telephone recovery support, transportation, a little bit of harm reduction services, naloxone distribution, fentanyl test strips, xylazine test strips. So we distribute that with no questions asked. We also have an outdoor naloxone box where folks can help themselves if they're concerned about the stigma of coming into our space or if they need it on the weekend. We also provide a big piece of what we do is provide links and linkages and connections to recovery resources in the community, whether that's recovery housing or treatment or food, whatever we can do. We tell folks that if we don't know where to find the resource for you, we'll find it. If we don't know right off the bat, we can call somebody who knows that. We have about 20 different recovery support groups a week, and those go from traditional 12-step NAAA to Wellbriety, all recovery meeting, smart recovery. We have a monthly grief and loss group. And the other thing that we do monthly is we have a social event, a recovery oriented social event, where we partner with a couple of other organizations in our community and offer pizza, sodas, cookies, and more fun than you can stand. So we have probably 20 or 30 different board games. And that has been a very popular event, and that kind of doubles as a fundraiser. We ask for a $10 donation, but nobody's turned away. And I will just say that we are the first recovery community center in our northeast region of Tennessee. We're in the Tri-Cities, Johnson City, Kingsport, and Bristol. And we're the first, and we're brand new. We've been open a little over a year. We were founded in June 2022 and opened our doors January 3rd, 2023. And I say that to just kind of highlight the need that we've already served well over 8,000 people through our groups and events, representing probably close to 1,000 unique individuals. And our numbers are underestimates because we don't require anybody to sign in, although we encourage them to, but we don't want any barriers at all for folks seeking recovery. So if somebody wants to remain completely anonymous, they totally have that option. So we also have transportation, and that we can help folks get to recovery or health related or criminal justice related appointments. And that's kind of who we are. And if you come here, what it's like is a lot of times folks, when they come in for the first time or anytime, they're likely to hear a lot of laughter because we do have a lot of fun at JCRC. And I would love to just provide an open invitation to anybody that wants to come visit us. We love visitors, and we love JCRC. So thanks, Bettina and your crew, for highlighting Johnson City Recovery Center today.
Thank you, darling. I love, what you're saying about that you're greeted by people laughing and having a good time. That is so important and so wonderful to hear that that's happening for you all. Sounds wonderful. All right, and we'll hear more from you, Jadi, as we go along from moderator discussion. So for now, I will move us on to, I believe, our polling questions. So as you know, we're always trying to capture who's in the room. So if you can start that survey for us, and towards the end, you will have questions about the content to come in today's seminar. So if you just want to complete here these boxes, and then you need to use the bar on the right to kind of go on to the next question. And then when you've completed all of them, the blue submit button should light up for you. If you're experiencing any problems, let us know. And for the last one, you can do multiple answers if you so choose. And especially if you're willing to share more barriers that you are aware of, please do put them in the chat. That would be super helpful. And in doing this polling question, we all get a nice moment of Zen to have a moment of mindfulness, of quiet as we're waiting, right? How are we looking, Olivia, on the percentage?
Almost 60%.
Amazing. Thank you, guys. We're going to go up to 75% before we move on.
Just hit 80.
Oh, wow. You guys are amazing. Great. Thank you. All right. If you want to close this and then people can take a look, I'm going to scroll down to the questions about today. What do you think is the most challenging barrier to creating linkage between RCCs and clinical settings? And most everybody thought that lack of awareness of RCCs would be the primary barrier. And then second came in lack of staff and funding for clinics to help make that connection happen, probably also among RCC staff. And then when we talk about what is a lack of knowledge, what is this lack of knowledge impacted by? And the selection of the options that most people, or the most responses came for, was inconsistent terminology when describing these organizations, which was 49%, low amount of RCCs in the country. So if you don't happen to be a neighbor of them, it's tough to know that they exist, and low outreach from RCCs to medical settings, which 46% of us thought was the case. All right, perfect. So with that, let us move on to the next piece. We are going to be hearing in a moment from two prescribers who are with us, who can share their experiences and give us insight. We wanted to set the stage a little bit though, and we are sharing some data with you guys, which are interim findings, not a large sample size, but something to just get us all going on what we do know. So together with the Detroit Recovery Project and the Northern Ohio Recovery Association, our research program here within MGH is currently doing a study where we are reaching out to directors of clinics that provide medications for opioid use disorder, and we are asking them to complete a survey with us. We're also asking them to do an interview, and we'll share that in a moment too. We focused on RCCs that are serving Black communities as defined by the census in their zip codes. So we identified 47 RCCs that are serving Black communities, and then we're trying to find clinics near them that provide medications for opioid use disorder. And we then ask those directors about recovery support services in general and recovery community centers in particular. When we do ask them, we are using this definition, and we decided to put the definition here because we all talked about terminology and how it differs from place to place. So when when we talk about recovery community centers, we define it in our study as brick and mortar places located within the heart of a community that serves as a central recovery hub by providing a variety of support services for people in or seeking recovery. And Mark, you're not late. It's always good to have you. All right, moving on to the next slide. So what we did is we asked them, are you familiar with the following recovery support services? And you can see that these center directors, these clinic directors, so directors of clinics that provide medications for opioid use disorder, 100% of them were familiar with recovery housing, and most of them referred to them as part of their standard of care. It becomes less so when you go down to recovery community centers, where about 70% of them were familiar, which is great, but only half of them would also then refer their patients to the recovery community centers. So we asked also what kind of concerns. So if you're not currently referring, or if you're thinking referring your patients to an RCC, what kind of concerns get talked about, or are you thinking about as you're doing this? And the number one concern that clinic directors shared with us in this survey was that they simply don't know enough about RCCs, who they are, how they're funded, how they operate, what services they do, how they're located, who's in them. They just don't know enough, and they just feel uncomfortable sending folks there when they don't know exactly what is happening there. Interestingly enough, we have there's very few people who express safety concerns, but there's also this idea about information overload, for example. You can only tell people so many things to do, and which one do you highlight, that kind of stuff. So these are the kinds of concerns that we heard about people. I will say this lack of effectiveness. So we are advancing the science on recovery community centers. That's our goal here. And we do want to do very strong empirical data to show how RCCs confer benefit. And if they do, not having that literature in place is not a big deterrent, at least in the survey. Only 30% said that was a deterrent for them, because there's so much anecdotal and other evidence that's not, a randomized clinical trial, but other evidence that exists. Then we ask, how valuable is it to tell patients about RCCs? And everybody, despite having concerns and despite not actually doing it, everybody thought it would be valuable to tell patients about recovery community centers. So that was in theory when we just kind of asked abstractly. And then if you go to the next page, we can then see that we became a little bit more concrete. So for each one of the RCCs, we actually knew, each of these clinics, we knew which RCC was near them. So on the next page in the survey, clinic directors were presented with information about the RCC near them. This is just an example. Each of them had a different one. And we would share with them the name of the RCC, the exact address, their website, and how far it was away from their clinic. And then we ask them, so do you know this RCC? And only 30% knew about this RCC near them. Even though on average, and this is only 10 clinics, this is an ongoing study, so these are very interim, but these clinics were only about 4.8 miles away from the RCC, and only 30% of the clinics knew about them. All right, moving on to the next slides. We did have a great fortune that 4 clinic directors set aside time to talk with our team, generously sharing their thoughts and insights with us, like Judith and Susan will do with us in a moment. And they shared with us that some of the concerns that they had was when they do try to figure out what RCCs, the website information they see seems to be outdated. Doing electronic information transmission doesn't really work well for patients, or not for all the patients, as some of them are not savvy with technology. Was a general lack of awareness of RCCs and what exactly they do, especially since it differs from RCC to RCC. Just logistical issues. They didn't have a flyer in hand. They didn't have something they could just provide. They didn't know a specific staff member's name or phone number to do a warm handoff. All these things take time and effort to put into place. So those were the barriers. Transportation too. If it's people have to get from one place to the next. And then also, engaging with another outside resource if patients will be willing to do that. These were the barriers that got talked about in our 4 interviews to date, and hopefully there'll be more to come. For the solutions, we have things like having a centralized database, which is why we're always asking you all to tell us about your RCC so we can start supporting those efforts. More outreach, more connections, more connecting with RCCs would be a way to do it. There should be more multidisciplinary teams. Maybe they can have an in-house RCC. Maybe there can be peer recovery coaches that could, if there's more funding within clinics, that could allow those services to take place and those connections to be made better. And then there should just be the clinic director said that would be great if you were just given flyers, pamphlets, things we can hand out to support a better infrastructure network between RCCs and the clinics. All right, so this is what we've gathered from our interviews, but this is very macro level. Today we have with us, if we go to the next slide, Susan Calcaterra and Judith Feinberg, and you can see their affiliations here. And they have done a lot of amazing work in this space. So we have some questions for them, but I want to start, Susan, with you, if you wouldn't mind. If you could tell everybody here who you are, who you're working with, and how you do this work.
Hi, everyone. Thanks so much for having me, Bettina. It's been really fun to learn about RCCs, and I'm so grateful to be invited. So my name is Susan Calcaterra. I'm a physician. I practice both addiction medicine and hospital medicine in the hospital setting. In our practice, we initiate medications for opioid use disorder treatment, and we enroll patients in methadone programs and link them directly to methadone as well as buprenorphine. And I think, one of the things that really has resonated with me about the recovery center community center is that, a lot of our patients lack social support, and social support is so key for recovery, feeling cared for, feeling that someone's listening to you, and just being kind to people. And so I think these RCCs is really a wonderful opportunity for people that are ready to reach out for help, to have a warm place to go to.
Great. And so for the people that you see, so you're connecting them with medications as you're going, how do you get that support right now? So have you been working with RCCs, or how does that currently work? You just hope that they kind of find it themselves, or what do you do to do that aspect of it?
So I, like many of the respondents to your survey and your key informant interviews, I was not aware of RCCs before meeting with you and your team. And, I think it depends on what services they've already sought out or they want to seek out. So oftentimes if people are not ready for full recovery, we can send them to syringe service programs where they can get syringes, fentanyl test strips, xylazine test strips, much like Dottie mentioned. And at our local syringe service programs, they have snacks and food, and they have actually mailboxes where people can have their mail sent to. So that's one place. If they're interested in recovery, the traditional route, we give them resources for peer support, AA, Smart Recovery, etc. And then, we do partner with methadone clinics that tend to be more patient-centered. They're affiliated through the university. They're not owned by large conglomerates, and the people that work in those settings, in my opinion, tend to be more patient-centered and caring. And that's where we generally refer our patients.
Great. Thank you, Susan. And Judith, how is it looking? So if you can first introduce yourself and tell us what you do in your work and who you work with.
So, Judith Feinberg, as I mentioned, an infectious disease doctor, but my primary appointment at West Virginia University is in the Department of Behavioral Medicine and Psychiatry, because I really work at the intersection of substance use disorder and its medical complications, infections, and overdose. We have a very large, the largest in the state, outpatient treatment program that primarily uses buprenorphine. Methadone's extremely limited in West Virginia, and there's a moratorium on any new methadone programs. So we do not offer methadone, which I think is really a shame. We would like to be able to expand that, but we're stuck with this moratorium. So, like Susan, before I met with the team here, I was not aware of what a recovery community center was. We do have various organizations across West Virginia that offer some support. Not all of them are brick and mortar places as the way it was defined in the survey, but many are They don't do quite the same range of things, for example, that Dottie described for her center in Johnson City, Tennessee. For example, in Morgantown, we have a facility called the Friendship Room, which is a place to drop in, get snacks, get information, get referrals, get out of the weather. A substantial proportion of individuals with substance use disorder in West Virginia are homeless. So getting in out of the elements is really a nice thing for people. But it's not necessarily focused on recovery. It's for anybody who is dealing with substance use disorder and looking for either just some relief from the elements or, other forms of support. So I do think it's actually a wonderful idea, and I would like to see recovery community centers be developed in West Virginia, because the idea of centralizing a lot of different forms of support in one location, I think, is a very attractive idea. And I do wish we had this. So now that I've been introduced to it, I'm going to work on trying to help develop these similar kinds of centers. But as I said, we do have things available to people scattered around the state. They're just not so centralized in such an organized way as the way that has been described here today.
That makes a lot of sense. And I was going to ask about something else, but I'm going to take Michael's question first. And Michael just asked us about what moratorium on Medicaid supported recovery, why it was issued in West Virginia. If you can just tell people about it who are not familiar.
So it's not, I'm not sure what, the moratorium is on methadone.
Okay.
Not
just methadone, not buprenorphine, just on methadone.
It's very specific to methadone. There are 9 methadone clinics in the state. They are all private for-profit organizations. And we have had a moratorium in place for a while. And despite our efforts to get the moratorium overturned, this last legislative session, we were not successful in doing that. And I think that is really a shame, because you need alternatives. You need choices for people. Some people thrive on buprenorphine, others thrive on methadone. You need to be able to offer individuals what will work best for them. And if you stop and think about it, really, we have so few medications for opioid use disorder. We don't have any real medications for stimulant use disorder. And, if you stop and think about it, like, think of how many medications there are for blood pressure, right? If you have hypertension, there's probably 30 choices, maybe more. And so you can pick and choose for the ones that will work best, whose side effect profile will be least disturbing to a person or not disturbing at all. And so when we have so few medications to work with, it is such a shame for any of them to be so restricted. But we have 9 active clinics, and for the time being, that's all we have. And I can't tell you why. I can't tell you why. I think politically, West Virginia is not these days a very expansive environment.
Right. And I will say, Judith, that I had no idea that there's 30 options for blood pressure medications. So I hear you that this is a lot more limited in what we can do here to medically support recovery. So the question that is coming, but what I wanted to ask you guys is about the barriers you see. So I am employed by hospital, I'm a researcher, and I know there's a lot of administrative work we have to do and a lot of rules and regulations we have to follow, which make at least research incredibly slow and challenging. Do you see barriers that you face as working in these kinds of settings that allow you to refer to recovery community centers? So you are already referring to smart recovery, you're already referring to 12-step. Is there any like administrative limitations, or is it really just a matter of knowing who's there and how to connect? What are the barriers you would face if you had an RCC near you? What kind of barriers would you be facing to making sure that a center of care, every patient who does get set up with medications, with you guys, would then also be learning about RCC as a potential options to pursue for themselves? And I don't know who of you wants to go first. Either one of you.
I can start with that. I mean, I think the biggest practical barrier to anything in our state is the lack of public transportation. So if, you know, if you can't walk from the major homeless encampment or from where you live, you can't walk to a recovery community center, it's going to be really hard to get there. And, you know, when we do research studies, sometimes we pay for, you know, ride share to get people to their appointments. So if you needed to rely on something like that, then, you know, you'd need a source of funding to do that. In more urban settings, when I was doing research in Cincinnati or Baltimore, you know, we would contract with a local taxi company to pick people up and take them home. But, you know, that's just not an option where we are. So first and foremost would be, you know, location, and putting these places in locations that would be accessible to the largest number of individuals, is we just don't have transportation. I think the other obstacle that would really be important in the West Virginia setting is that everything related to substance use disorder is so stigmatized. And I think dealing with community stigma, you know, being able to rent a space where the landlord would let you do this, being able to overcome community objections and kind of the NIMBY, the not in my backyard phenomenon, I think would be significant barriers.
And that's something that RCCs are able to do in terms of, you know, they do find places, and that there are definitely challenges, but they do open doors nevertheless. Dottie did it, and they do work with communities. So there is nothing though from administrative end that says you can't refer here because of XYZ. Like you're allowed to, you're free to make these kinds of referrals as a prescriber in your environment.
Yeah, that wouldn't be an issue at all. It's really accessibility to the individual.
Great. Susan, is the same true in your setting?
Yeah, I definitely agree with transportation, and especially where we are in Denver, I'm in Denver, there's increasingly been these homeless encampment sweeps where everybody's belongings are just taken and thrown out. And so people have to move from encampment site to encampment site, making their life incredibly destabilized beyond how it was already destabilized. This leads to changes in the knowing what are in the drugs that people are using, increases overdose, loss of, you know, as an example, I have a colleague who does street medicine, and she was caring for a pregnant woman who she had sort of established a relationship with, and there was a sweep, and she lost track of this woman. And so I think the lack of transportation, the sweeps, not having phones is a huge barrier. So we just received a grant to give people phones. This is the purpose being that if they don't show up to an appointment, we can call them and say, where are you? And we have support to send a car to come get them.
And this is for clinical work or for research work?
Clinical work.
That's amazing.
Yeah. Thanks to the opioid abatement funds in Colorado. We have funding to do that. I think with respect to your question about administrative barriers, there are none that I can think of. We, as I previously mentioned in another conversation, we have a group of people that are volunteers with AA come into our hospital and meet with patients if they're interested. So if there are 2 RCCs in Colorado, we would love to have them come. There are no barriers to have them coming into the hospital just to talk. They're essentially a visitor. I think we had talked before about we use Epic as our electronic health record. If we had a representative from the RCCs in our community give us a 20-minute presentation, we can build, we call them smart phrases in Epic to put that information using a smart phrase in the discharge paperwork and talk to patients about the RCCs. I mean, an RCC is complementary to medications for obedience disorder. They're not in contrast, right? So I think the more we can offer our patients, better. Just the lack of awareness is the hugest barrier outside of transportation and displacements, I think, are the barriers that I can think of.
Great. So what about what about time? So when we call, for instance, like I mentioned that we were able to get, and this is mostly Olivia here on the call, who's been able to get in touch with clinic directors. We always find that on the other end, it's extremely busy, that the front desk staff has a million calls, they're having so many patients and a really compressed time scale early in the morning. Is there space and time for staff to engage in conversations of saying, as you're leaving, let me hand you this flyer for an RCC and let me tell you about who you're going to see there? Is there space and time for that?
Absolutely. I mean, the way that our team works in the hospital is we have social workers, we have a person with lived experience in recovery, a peer. They meet pretty much with every patient that expresses an interest and talk about post-discharge treatment. And this is part of the conversation we have if patients are interested in intensive outpatient programming or one-on-one counseling. We talk about that with them. We give them resources. And so this would just AA Smart Recovery, this would just naturally fit into that conversation we have with any patient that expresses any interest. We also provide harm reduction, safer use, et cetera. We have these conversations. So for me, this is a part of what we do in our daily practice.
We have a very similar setup. We attempt to cohort all the patients admitted to the hospital who have substance use disorder and are admitted for some medical condition, and we cohort them on a single ward. Sometimes that ward is 100% filled and there's spillover to other locations. And these are individuals, for example, who have endocarditis or, something serious related to their substance use disorder. And we have 2 peer recovery coaches embedded in this 24-bed unit, which sadly is at close to 100% or 100% plus occupancy all the time. And we also offer, when patients are hospitalized, in addition to support from the recovery coaches, we offer people medications for opioid use disorder. We can even start methadone if they live in an area that has one of these methadone clinics, and if that's a medication that looks like it's going to work for them and is something that they want. And these are integrated services when we have individual and group therapy in the hospital. So we do everything we can when we have, after people have been in the hospital long enough and been treated so that, they're not acutely, desperately ill anymore, then, that there really are a lot of forms of support and services that we offer them and that people take advantage of, and has really helped our readmission rate, has significantly lowered our readmission rate, has also significantly lowered our length of stay, because people are more prepared to leave the hospital and be in charge of their lives.
Right, very true, very true. I see here a comment from Vinod. And Vinod, would you be okay just sharing your observation out loud so people don't have to read? And so Susan and Judith can also hear it.
Sure. Nice to I'm glad to hear this conversation, and I appreciate the comments from Susan and Judith. As a the director for a clinic at Mass General Hospital, our clinicians have like a lot on their plate, and they're trying to deliver either the psychological care in a group setting or an individual setting, trying to manage medications. There's considering internal referrals. People know about AA, NA, Smart Recovery. Sometimes when there's a hope that maybe someone else can do this, but also I just don't know that recovery community centers, ironically in Boston, where there's one train ride away, isn't top of people's minds. And because there are just so many things going on in our particular hospital setting that people don't pay attention to it as much as they might. So I just wanted to relate it. I think that's been part of our team's challenge in actually using it as much as we ought to be.
In terms of, there are so many great options that clinicians can refer to and connect patients to, that there's just one too many things, or?
Well, I wouldn't necessarily all call them great, but familiar. And I mean, if they were all great, then we would be licking this problem and not really worrying about it. That's not the concern. Substance use is really, as we all know, is really complicated, and there's so many aspects to the dynamic that people are navigating. And I think the recovery community centers have a really unique opportunity to be immersive in a way that can be helpful in terms of like generating a new environment. It's one thing to come in for an appointment, but to like exist as part of a community in a different kind of environment is something that not as many of the interventions around substance use offer. So but some of these other things are closer. It's within the clinic, within the hospital system, or within like the patient's named family or something like that, that the attention there often isn't the opportunity to think broadly about what are the other elements that ought to be integrated into the person's care.
I mean, I think that you're exactly right about that we as clinicians just have so many aspects of the patient's care and life to think about. But I love the idea of having things linked into the electronic medical record so that, for example, at discharge, if you haven't thought of saying this to the patient, there the information is. And I think in many ways, I'm not a big fan of the electronic medical record. You can see from the color of my hair, I've been a doc for a long time. I gave up my paper and pen charts, kicking and screaming. I really don't find a life typing at a keyboard to be a productive use of my time. But one of the really good things about an EMR is that if you set up the logic, then things can get linked and can happen that you don't necessarily have to yourself remember to do at a given moment. So I think that is certainly an aspect of, the electronified life that we live now, that could be advantageous. And I think other questions in the chat, I mean, just as Susan mentioned, we welcome people to come and talk to patients when we're in the hospital. They're visitors. There's not an administrative hassle to this. There's not a block to this. So the idea is just, having those people be aware that they're welcome, and whether they're peer recovery support people or people from the local recovery community center, whoever they are, they're always more than welcome. I mean, these are needy individuals. Anything that you can offer that could enhance recovery and enhance their lives, I think is valuable and should be supported.
Perfect. And I was going to mention that too, that we had a conversation about what that would look like. Before I'm going to ask you guys for what that look like. Michael, you mentioned as well, request in services from our centers, and we would be happy to come and speak. Do you have experience? Have you done this? Like, how did that go when you did go to medical settings and told them about RCCs? Would you be able to expand on that? If that's okay to call on you, otherwise we can also.
Yeah, sure. Yeah, so I'm Michael Bryan. I'm actually the regional coordinator for BSAS for the recovery support centers in Boston, Metro West, and the Southeast regions. I had the pleasure of developing a recovery support center in Fall River, Massachusetts. And we have two hospitals within my city, St. Anne's Hospital and Charlton Hospital. And we established great connections with both hospitals, where we provided monthly in-services just to keep those connections fresh, as we know that there's a high turnover rate, specifically in the EDs, right, with social workers and ED staff. And we wanted to make sure that folks knew where to find us when the need was great, specifically with, post overdoses. And then those that were an inpatient for, SUD-related illnesses, endocarditis, maybe MRSA, other related illnesses that resulted in substance use disorder or co-occurring disorders. So we developed these relationships from onset. And we knew when there was a disconnect because the calls would stop, right? So we knew that keeping ongoing engagements and just keeping a fresh face and building these connections, not only did it develop great stakeholder relationships and community partnerships and developing that rock that we wanted, it helped this flow of community as well. So I'm pretty sure we have 6 centers now too, 2 of them which are new in Boston. So I'm sure they wouldn't mind coming and doing frequent, even if it's on a quarterly basis, sitting, dropping off pamphlets, sitting with staff, and just developing, some good partnerships and stakeholder relationships. I think it would be good for both parties. So
yeah, I love this ongoing support and ongoing connectivity, because as you say, there's a lot of staff turnover and then things get dropped and lost and less connected. Great points. On Tuesday, Judith and Susan also talked about what kind of things they would like to hear on a first intro to establish this kind of relationship. Could you guys share, like, if an RCC said, oh, we could come and talk, what would you like them to cover? Like, how long should a presentation be? And what key information would you need to get from such an introductory meeting? Either one of you guys. Do you want to go ahead, Susan?
Sure. I was going to say, go ahead, Judith, because you were unmuted, but I
Oh,
will.
perfect then.
I'll jump
Let me
in.
go to-
So what I had mentioned before is every month our team meets via Zoom. Our addiction medicine team meets via Zoom, and we just talk about updates and interesting cases. And we often have guest speakers come and talk about their. Last month we had a group of people who provide nicotine replacement therapy to patients in the hospital. So I just have them come and tell us what they do. So this would be a perfect opportunity for someone from an RCC to come talk to our team, give us the rundown on exactly what Dottie did at the top of this conference. Really succinct presentation. What do we offer? What kind of people do we want coming to our RCC? Costs, and Dottie said it was free. So these are the things we need to know. And then, we have short attention spans. The people that work in the hospital, we have short attention spans because things move so fast. And so we like to hear it a lot of times. The more times we hear it, the more likely it will be to stick. So that's all I need to hear. Basically, Dottie's presentation was perfect. She got me at hello.
She does that, doesn't she?
Yeah.
So true. Judith, what?
I think similarly, we would certainly be open to what an organization would want to present. I think the key thing when you're talking to hospitalized patients is the state of acuity of their illness and, you know, kind of what they're ready to hear. So sometimes that would need to be pretty focused and pretty short with a promise to come back. On the other hand, after people gotten antibiotics for a week or 10 days for their endocarditis, often they're just bored. And, you know, hearing a longer presentation, I think would be perfectly reasonable. So I think that to some extent this has to be tailored to, individualized to what the situation is. But, you know, other than that, I can't imagine any kind of placing any kind of strictures or rules or constraints on it. You know, I think whatever's available in the community is potentially valuable and is something people need to learn about.
Mm-hmm. And then Ashley, he had a comment about direct, instead of connecting just with the staff, also connecting to the patients. Ashley, do you want to speak to that? And I think Kristen had the same kind of idea about direct outreach. If one of you guys wants to outline it.
Yeah, this was just following up on what the physicians had talked about with the clinicians just being sort of overloaded with you know, different connections that they're going to need to make. And is it, and I've done that where I've tried to like talk to clinicians about a program that we had in their community for adolescent, young adult treatment, and got 0 referrals, even though we sort of repeatedly went back to try to remind them, stay on their radar, you know, bring them cookies, things to make them remember us. But I'm just, I do think it's a lot that they've got on their plate, and is a better path for the RCC staff not to talk to the clinicians and sort of these one shot, remember us, versus something that's a more consistently going in to talk to patients, or some sort of other way of connecting. If maybe that could be set up as a system, a routine system, if that would have more success in connecting patients. And I think Kristen was mentioning sort of the warm welcome, warm handoff kind of connectivity that peers can do, where they can actually take you to the RCC when you get out, or, you know, meet you there, or things that would be a closer connection that might be the peer support element that might make a difference for connecting people.
I should mention that we have a weekly care coordination conference that for every single patient, and this is everybody, this is infectious diseases and you know, behavioral medicine and addiction and social work and nursing and cardiology and the cardiovascular surgeons and everybody who's involved in the care of these patients, including the 2 embedded peer recovery coaches. And, you know, as patients get readier and readier to be receptive, you know, and not so sick and be able to hear what's available, I mean, that's the setting in which that would come up. And I think, for example, in our environment, our peer recovery coaches would be the, you know, the ideal people to introduce you know, the idea of talking to someone to a patient and helping make that connection. I think it's valuable for the clinicians to understand the range of services in their community, but I don't think this at all needs to go through the clinicians.
Yeah, I will say that even just doing the study, we always come across a lot of barriers where people can't even come into a waiting room to hang up a flyer without some kind of approval. There's, you know, protection around the patients, and it differs by state to state, by situation to situation. But these are the kinds of barriers we've seen in the research end, and I can imagine on the actual telling people about RCCs, and that'd be the same way, that it's harder probably to engage, like having people physically located in your area talking directly with patients. Is that something that can be set up, or do they have to be always hospital employed to interact with patients?
I don't know. I don't see real administrative barriers to, you know, having people talk to patients about resources. Do you, Susan?
You know, this has come up in a different way. We had discussed partnering with another OTP to complete direct linkages to the OTP. And what I heard from our leadership was that if we were going to do that, we had to sort of do it with all of the OTPs in the state. We couldn't have preferential referrals to one over another. But with the getting people from AA and NA to come into the hospital, for some reason that has been allowed. And so I'm wondering if it has something to do with like a volunteer sort of, sort of thing versus making referrals to treatment, maybe. I think I think there are many people in recovery that part of their recovery is to do service to their peers. And so if there are people that can come in to the hospital as a volunteer, I think that's a different thing.
Yeah, I hear you. Donna, did you want to share your comment? I see it in the chat here.
Oh, sure. I was just going to say that some of what we do, our peers at our RCC, we go into the different organizations, treatment facilities, or medical clinics. If they want us to come, we come in and we'll talk to the patients or the clients, tell them a little bit about who we are, give them a little brochure and our calendar. And it is incredible how many people, when they're discharged or if they are just looking for more support for recovery, come to us because we went there. We also go in anytime we're asked and talk to staff and treatment teams about who we are. And we have a lot of addiction medicine clinics that refer to us because there is so much stigma, especially where we are. There's still a lot of stigma around medications for opioid use disorder. So we get a lot of the referrals and patients from the clinics here because all of our groups, even if it's, traditional 12-step, all of the groups, in order to host a group here, we tell them that everybody's welcome in the meetings. And if they're not going to be welcome in your meeting, then we're probably not the best place to host it. So even our NA meetings are super medication friendly, But yes, that's warm handoffs. We try to do that as much as we can, if we'll pick them up and bring them here and give them a tour. We have some of the clinics and programs do field trips with their clients and patients and will bring them here. And so we've really worked hard to engage the community and let folks know that we're here, we're affirming, we welcome everybody.
Very cool. And I also wanted to, I know we're almost out of time. Annie, I was hoping that you could also reflect back on from your part of the world. You'd mentioned bandwidth and knowledge of RCCs. If you can say who you are and we talked previously too about this topic.
Yeah, so I'm Annie Peters. I am Director of Research and Education at NATAP, or National Association of Addiction Treatment Providers. And so most of our members are private treatment centers. Well, it's kind of 60-40, but and I would say the thing I heard about reaching out is similar to what people said about bandwidth, and we have so many referrals. I'm thinking about coming in. I do think coming into private treatment centers, there can be a barrier because of the knowledge and not knowing that this is a free peer-driven service, and I'm really understanding what this is, because they'll get, people who they'll think it's a business if they don't know what it is, and think it's a business that is trying to make money and want the patients, and what they want is time in front of the patients. So, yoga and fitness people and coaches and stuff, constantly asking, can we come in and see your patients? Can we come in and see your patients? And I think just not knowing what it is. And so, Dottie's thing, I think at the beginning was just perfect. We're a free service. It's run by peers. We have AA meetings, particularly if they're 12-step program centers. And we just want to provide a safe space for your patients, and we're not financially driven. And if we can come and talk to your case managers, that'd be the clincher, the case management staff, not necessarily the clinicians, but in those types of centers, I think that would be the way to go. So.
Awesome. Yeah, that connects to many of the things that we're going to we're talking about too. And I wanted to go into this idea of exploitation because it is unfortunately an issue here. But before I do it, I want to acknowledge that we are at the hour. So we will stay on for a little bit for those of you who have time to chat a little bit more, but we will stop the recording